Keri Lunsford come from the William Conner Medical College, Houston Methodist Hospital, USA. Please.
Thank you. I really want to thank the organizers for organizing such a wonderful conference and for inviting me. This is my first time here, so I'm very excited to see your city. I want to talk a little bit about liver transplant for cholangiocarcinoma, and this sort of combines some of the things that we've heard about throughout the day. Some of the things will be a little bit of a repeat, but I do want to sort of touch on the transplant-specific aspect because the thinking and the planning for transplant is a little bit different, as we've heard, for transplant compared to surgical resection. So, of course, with transplant, what we're primarily concentrating on is intrahepatic and perihilar cancer. And as we've heard, if a patient does not have resectable disease, the prognosis is grim. So our focus really should be in resecting the cancer whenever possible. Unfortunately, only about 40% of disease is resectable at the time of diagnosis, and then 2/3 of those patients do ultimately recur. And then there's challenges with resection. Not all of the diseases that looks resectable on imaging is actually resectable because often it's infiltrated beyond the radiographic tumor extent, or it's located near critical structures or wrapping around critical structures that can't be resected or require extensive reconstruction. So liver transplant offers an alternative in these situations and in select patients, in that it can sometimes achieve tumor-free margins that wouldn't be possible with resection. It also treats this parenchymal invasion because all of the parenchyma is removed, and it also removes the underlying tumor. Wrong way. So when we're looking at patients for pre-transplant evaluation, of course, we're going to use most of the tools that we've already heard about. ERCP is necessary for diagnosis because what has been alluded to is we really, especially in perihilar cholangiocarcinoma, we cannot perform any type of transperitoneal biopsy because that would exclude the patient from the transplant criteria by UNOS. We would need, in these situations, we do need to have pre-transplant drainage of the biliary system because oftentimes patients are waiting a year or more before they're transplanted. Cholangiopathy or cholangioscopy can be done and is sometimes done in order to help us diagnose or localize for biopsy. And generally, we recommend EUS in most patients, primarily to evaluate the perihilar and gastrohepatic lymphadenopathy and to perform FNA of those in order to diagnose any lymph node metastases in order to qualify a patient for transplant. We generally will use at our center a high-resolution triple-phase CT scan with very thin cuts for either a cholangiocarcinoma protocol. I think it's because the CT scans that we get at MD Anderson or at our center tend to be a little bit better at identifying tissue infiltration than the MRIs do. We do add a chest CT scan for staging. And then on the majority of patients, especially if they have an elevated CA19-9, and when they come in for a transplant evaluation, I'll go ahead and order a PET scan. And this is not necessarily to evaluate resectability or the local tumor extent, but this is to identify for distant metastatic disease. And in some cases, we've been able to identify bone or lung mets, which weren't otherwise identified by imaging. And it basically saves the patient the time and the stress of going through a transplant evaluation when they wouldn't have been a candidate. So first I'm going to focus on transplant for perihilar cholangiocarcinoma. So initially this was reported in 1998 by O'Grady et al. Out of London, and they reported a series of 26 patients, of which they had a 38.6% one-year survival, and by 4 years all the patients had expired. So the results really were not ideal initially. And probably the initial outcomes with the early series for transplant for perihilar cholangiocarcinoma were because the patients had poor tumor biology, perineural invasion, or lymphatic invasion. They tend to be transplanted with very late stage disease, and there was really a lack of consistent and really no neoadjuvant therapy that was employed. So this sort of brought us up to around the 1990s, early 2000s, in which time a group out of the Mayo Clinic developed the Mayo protocol for liver transplant for perihilar cholangiocarcinoma. And this is actually the protocol that's, with some minor modifications, is still used today at most of the U.S. centers. So the Mayo selection criteria are early stage hilar cholangiocarcinoma. The patients are diagnosed not necessarily always by having a tissue diagnosis, which is different than some other areas, but basically patients have to have a malignant appearing stricture or mass with one of the following, either malignant cells on biopsy or cytology, aneuploidy, or they can have the malignant appearing stricture just in the setting of a CA 19-9 greater than 100. So a lot of times, especially in the setting of PSC, the patients don't actually have a tissue diagnosis, which the oncologists sometimes give you a little bit of pushback with treating a patient who doesn't actually have a tissue diagnosis of cholangiocarcinoma at the time of transplant. But for them to qualify for the transplant, they have to get neoadjuvant therapy. So the mass has to be unresectable, and if there is a mass present, it has to be less than 3 centimeters in radial diameter, with the absence of any lymph node metastases and control of biliary sepsis. In addition, the U.S. protocol excludes any intrahepatic cholangiocarcinoma from liver transplant, and patients must not have had a transperitoneal biopsy prior to, or a prior surgical resection or attempted surgical resection. The protocol itself employs external beam radiation with 4,500 centigray and 30 fractions plus 5 FU, followed by some intrabiliary brachytherapy, followed by with additional chemotherapy. And then the patients undergo a staging laparoscopy to rule out peritoneal metastases and for biopsy of the perihilar lymph nodes. At that point, the patient's then placed on oral capecitabine until the time of liver transplant. And there's some variability as to how long it takes to get to transplant. Generally, for some centers, and there's a lot of regional variation in how high the MELD score has to be before a patient would qualify for transplant. So then this is an example of a transplantable perihilar. As you can see, the radial diameter here was 1.94 centimeters. Longitudinal diameter, there's really no length or there's no distinguishing the distance of the tumor, but really it's this radial size that has been determined to be the main predictor of transplantability. So outcomes for the Mayo criteria, and this is in comparison to resection from one of the earlier series. They saw a recurrence rate for liver transplant in their series, and this was the Mayo series specifically, with a recurrence rate of 13% for transplant versus 27% for resection. The improved overall, so this did result, at least in this comparison, in improved overall survival for resection. However, when you look at these original patients, 42% of patients had no residual disease on explant. So they either had a complete pathologic response, and some may question, since you didn't necessarily have a diagnosis of cancer in the first place, did they actually have cancer? Which is a reasonable question. However, there's a large proportion of these patients who are PSC. Predictors of recurrence in patients tended to be patients who lacked pathologic response on explant, as well as patients with pre-transplant portal vein encasement. When they looked at the larger series, the results were not quite as good as what had originally been reported by Mayo. So looking for patients with a radial diameter of 0 to 3 centimeters, 5-year survival was 69%. And then looking for a mass of greater than 3 centimeters at a 5-year survival of 32%. This was a 12-center consortium, sort of combined retrospectively from the centers across the country that were doing transplants. So there's some difference between PSC-associated perihilar cholangiocarcinoma and de novo perihilar cholangiocarcinoma in terms of transplant. Patients with PSC have a 6.8 to 13% incidence of perihilar cholangiocarcinoma. They tend to present at an earlier age. They tend to also, because they're being screened, have an earlier stage of diagnosis, and but they also more likely have multifocal disease. So sometimes you're required to do a combined procedure with a Whipple or pancreaticoduodenectomy at the time of transplant. But in these patients, pathologic confirmation is often difficult. They've undergone multiple ERCPs before we finally are able to convince someone to give them treatment to qualify for them for transplant. The patients in this series, though, with PSC have a superior 5-year survival compared to patients with de novo perihilar cholangiocarcinoma who have a 5-year survival of 56%. So in the patients with de novo perihilar cholangiocarcinoma, the outcomes really are much more comparable with what's seen with an R0 resection. So as we said, so liver transplant is currently an accepted indication for liver transplant for perihilar cholangiocarcinoma meeting Mayo criteria as per the UNOS-OPTN guidelines, and that's within U.S. centers. The U.S. center must have an institutional protocol in place, so there's only, I think, about 22 centers in the country that are performing liver transplant for perihilar cholangio. Patients also will receive extra points on the waiting list to prioritize them for transplant. However, this sort of leaves out the other half of what I was saying I was going to talk about, which is intrahepatic cholangiocarcinoma. So as of 2014, the International Liver Cancer Association said that liver transplant is not recommended for intrahepatic cholangiocarcinoma because the results were well below what was published for other standard indications. And as we can see here, in the majority of patients compared with other cancers, the outcomes for intrahepatic cholangiocarcinoma were significantly worse and below what would be expected, especially for what really is the benchmark, which is liver transplant for HCC. So generally, unless you have over a 50 to 60% 5-year survival, it's not something we can consider a reasonable indication for transplant. There are patients with cholangiocarcinoma who've been transplanted, however, because oftentimes, as we heard about the diagnostic challenges earlier in the day, patients are diagnosed many times as having HCC, but then undergo transplant, and on explant we find that they had either a mixed tumor or a cholangiocarcinoma. So what Dr. Staposocian did is he collected from 18 multinational centers all of the data from these patients who had basically an incidental finding of cholangiocarcinoma on explant. And he got a total of, I think, 60 patients from this group, and then evaluated them based on their tumor sizes, either having very early intrahepatic cholangiocarcinoma, which is a single tumor less than 2 centimeters, or advanced intrahepatic cholangiocarcinoma, which was multiple tumors or tumors that were greater than 2 centimeters. Most of these patients in the series received local regional therapy. They excluded anybody who had received any pre-transplant neoadjuvant therapy, or chemotherapy, I should say. So in this group, with the very early stage, they saw very good results with very early stage patients having a 5-year survival or tumor recurrence of less than 20%, and a 5-year survival of about 75%, which is similar to what's seen with perihilar cholangiocarcinoma. The results were significantly worse in the advanced group, with recurrence of 60% at 5 years, and a overall survival of around 50%. But still not as bad as had previously been reported. So there's some other evidence for potentially doing liver transplant in intrahepatic cholangiocarcinoma. So in 2011, Johnny Hong had published a series out of UCLA which had evaluated in combination patients who had been transplanted at UCLA with either perihilar or intrahepatic cholangiocarcinoma. And what they found is that patients who had either had been treated with neoadjuvant therapy or patients who had an intrahepatic versus a hilar location, those patients tended to have improved outcomes compared to patients with a hilar location or patients who had not been treated pre-transplant. So in combination with MD Anderson Cancer Center and Houston Methodist, we had hypothesized that prolonged disease stability in response to chemotherapy may be used to select for biologically favorable intrahepatic cholangiocarcinoma for liver transplant. For criteria for this, we chose a stable a period of disease stability of greater than 6 months, and patients were required to continue on neoadjuvant therapy until the time of transplant. So we were prospectively evaluating these patients for enrollment in transplant for intrahepatic cholangiocarcinoma. So these are the specifics of the protocol. Basically, patients had to have biopsy-proven cholangiocarcinoma with an intrahepatic location, not amenable to surgical therapy, and no evidence of extrahepatic disease or lymph node involvement. The patients were allowed to have prior resection as long as it was at least 6 months prior to the time that they were listed for transplant and they met all other criteria. They were also allowed to have pre-transplant local regional therapy or radiation therapy if those had also been done. They were diagnosed based on PET as well as evaluation for additional metastatic disease. And then for neoadjuvant therapy, the majority of patients received first-line platinum-based chemotherapy plus gemcitabine. If they failed this or developed complications, they were allowed to switch to a second-line therapy as long as they were stable on this. And then targeted biologics are allowed on sort of a case-by-case basis. The patients had to be stable on with their disease for 6 months on any given regimen. And then they had repeat imaging every 3 months while they were on the transplant list. And then after transplant, we gave them an additional 4 to 6 months of chemotherapy. So to date, we've had 38 patients who have been referred for evaluation. 10 of those patients have been transplanted of the 16 that were listed. We did have one patient that was further downstage to resection after they were listed for transplant. 2 patients who were aborted due to basically disease or adhesive disease at the time of transplant. 2 patients who were actively awaiting transplant, and 1 patient who was delisted due to disease progression. Of the patients that were transplanted, the 10 patients that we've transplanted to date, you can see a median age of about 46 years. Only 20% of the patients have had PSC, and these patients were transplanted outside of the UNOS criteria without any exception points, so their median MELD was 7.2 at the time of transplant. They were generally on the wait list for about 22 months. For 217 days. And you can see that these were relatively large tumors as opposed to what was seen with hilar cholangiocarcinoma. They were often bilobar, often multifocal, and had a fairly extensive extent of disease. So if we look at the patients who were either delisted or transplanted, what we can see is that patients who were delisted, this is after the time that they were transplanted, or this is from the time of diagnosis, patients who were delisted have basically 100% mortality over time versus the patients who were transplanted who had an 83% 5-year survival rate following transplant or following listing for transplant. And then looking at recurrence-free survival for those 10 patients, at this time we have, for the 10 patients who are transplanted, recurrence-free survival is 57% at 5 years. And these are, as we said, some fairly extensive tumors with a median number of lesions of 3 lesions, the maximum single tumor size of 6.5 centimeters, and a total diameter, cumulative diameter of 8.5 centimeters. With, I believe, 5 of the patients having multifocal disease. All of the patients did have active tumor at the time of transplant, with the exception of this last patient who was transplanted. And this patient did receive local regional therapy plus a targeted biologic agent and was found to have a complete pathologic response on explant. Of the patients who recurred, which there have been 3 so far, we have the first patient. They all really actually seem more like progression of disease as opposed to true recurrences. The first patient was found to have at 4.1 at 4 months after transplant some enlarging lung nodules, and she had had sort of these stable lung nodules, too small to characterize prior to transplant. So this was really probably a progression of pre-existing metastatic disease. The second patient had a bone lesion that had actually been biopsied prior to transplant, but that bone lesion progressed post-transplant, and then she developed multiple lung, liver, and bone metastases, and she actually died. This is our one death about just over a year after transplant. And then the third patient remains alive at 3.5 years post-transplant, and he was found to have some omental metastases after transplant, and then developed, about a year later, developed a positive, omental metastases, but he had a positive perihilar fat margin that was microscopically positive. And so we have looked at the genetics in these patients. I mean, I think we're probably selecting for biologically favorable disease, although we don't know exactly what that means yet. And we'll need some additional research to figure this out, because you can see the majority of patients do have either an FGFR2 or 3 mutation, as well as the IDH1 mutation. And then we have 2 patients here, one with a BRCA1 mutation and one with an IDH1 mutation, who both received targeted therapies. So in conclusion, basically, despite the large tumor burden, these patients with advanced intrahepatic cholangiocarcinoma appear to actually exhibit fairly excellent overall survival and recurrence-free survival. These results are actually probably a little bit better than what we see with resection in this disease. But it's a very early series and a very small series, so we really need to have some additional patients accrued in order to verify these results and hopefully get exception for these patients and have it be an approved indication for liver transplant. So, overall, we should, I think, consider transplantation for hilar cholangiocarcinoma within our sort of bag of tricks for what we're using for treatment of this disease. And in addition, I think that transplant should be considered, at least moving forward, as potentially an indication for intrahepatic cholangiocarcinoma too. I'd like to thank everybody with the Methodist MD Anderson Joint Collaborative Committee who've contributed to all this work and to accrual of all the patients.
Thank you, Professor Lunsford, for your wonderful presentation. Is there any question?
Yeah, I think perhaps given the lateness of the hour, why don't we have the surgeons maybe come down, and then if anybody has any questions, to come down and talk to us here at the podium. That way we can release the rest of the audience for lunchtime. Okay. Oh, Dr. Nagino, you have something to say? Yeah.
I have some comment. Thank you very much for informative lecture. I agree the PSC-related cholangiocarcinoma are good candidate for liver transplantation. I agree, but de novo cancer is different. When we consider resection or transplant for cholangiocarcinoma, the most criticism in U.S. cities, the resection outcome is too much poor, high mortality, poor survival. This is most criticism. Another criticism is the criteria for liver transplantation. According to Mayo Clinic criteria, single lesion, less than 3 centimeters, without lymph node metastasis, rather early stage, but unresectable. But I can't imagine such lesions. I can't imagine. Not all, but almost all such lesions can be resected and should be resected. So I can't imagine. So next time, if possible, I want to see the CT or cholangiogram. And I want to know why the doctor, this lesion was inoperable. I know, I want to know. This is my comment.
A very valid comment indeed. And in fact, I think we have some of the authors from the paper from the Annals of Surgery that you wrote an excellent editorial for, to perhaps we can have a discussion about this. But in the meantime, if I can have the speakers from the surgery session come down, we'll release the audience for lunch. But if anyone has questions, please feel free to come down. Thank you.